Hi, my name is Jeff Stroup, professor of medicine at OSU Center for the Health Sciences, and I was going to give an update today of the 2019 novel coronavirus, COVID-19. Just a disclosure statement, I have no conflicts of interest related to this presentation. Some of the discussion that will occur about the off-label use of drugs in the treatment of COVID-19 will occur at the end. Obviously, there's no on-label uses at this time. Some objectives to go through here is to what is coronavirus, understand the concept of spike protein and what we're talking about, differentiate between SARS, MERS, and COVID-19, identify the common symptoms of COVID-19, and identify some myths and realities of COVID-19. This first slide, you've probably seen some of the images of COVID-19 coronavirus now. But one of the things that we're primarily looking at is this spike protein S. This is what is critical for binding to the receptors to facilitate entry of the host cell. So it's a unique picture, and I'll show you some EM photographs of it, but that spike protein is what we'd be focused on as it relates to our immune system reacting. So what is coronavirus? It's an RNA virus. It's an envelope virus. Regular human coronaviruses cause 30% of all of our colds. This is what we call a beta coronavirus, so a zoonotic virus. And this is what we saw in SARS and MERS, and I'll talk about those in a minute. So with the naming of it, remember the disease, it's COVID-19, but the virus is a SARS-CoV-2 virus. So severe acute respiratory syndrome coronavirus. And if you look up here at the top, these are the beta coronaviruses. So you have MERS, you have SARS-CoV, and then CoV-2, which is what we're talking about today. These are some of the EM pictures of COVID-19. This one in the top right-hand corner, you can see the spike proteins protruding. But this is the image that you've probably seen on magazines, on TV shows, on news stations throughout the last 3 months. So coronavirus emergence, as I said before, the cold, common cold, 30% of those are coronaviruses. But these beta coronaviruses are something somewhat unique. So we had in the past, we had the SARS, the MERS, and now COVID-19. So SARS, if you remember, was in 2003. This was a fast-spreading illness. Total number of cases globally at that time was about 8,000. Case fatality rate was about 9.6%. But it was a concern in 2003 when we saw it emerge. Again, in 2012, we saw the Middle East respiratory syndrome, or MERS, develop. Again, about 2,500 cases globally. Case fatality rate was about 34%. Now we have COVID-19. So as you know, on the timeline, back in December of 2019, the World Health Organization was alerted of a string of pneumonias in Wuhan, China. Actually, there's some discussion whether that happened earlier than that. There's a lot of conflicting reports that come out all the way to where we are today, April 16th, where it's a worldwide pandemic. So one of the questions is, how did this start? Lots of concerns, questions, and I don't think we know the real answer at this point. There was some question, we do believe it does come from bats. There was some debate early on whether a bat infected what's called a pangolin, which is an animal in China. There's some question about, could it have been spread by bats to dogs, then to humans? And then, of course, there is a lab in China that there's some question about the role that lab played. So I don't believe we have the straight answer on what was the basis of the cause. That is still being investigated. I'm sure we'll hear more about that. What we do know is that in 2015, this article published in Nature Medicine identified a SARS-like cluster in bat coronaviruses that they were identifying, and they were getting bats and they were identifying these coronaviruses, and then also this pangolin was also identified there. So there's some relationship early on between the bat and the pangolin. We don't really know at this point, but this was in 2015 that this was identified, this SARS cluster that was circulating. What we do know about the virus is a lot of information. We know, I mean, probably in our time, we've never seen so much information come out and be published early. And there's a lot of data out there, but I would remind you, a very few amount of it is peer reviewed at this time. A lot of it has been accelerated. It's online before peer review. We've had, case reports come out. We've had images come out. We've had cultures, PCRs, antibodies. So we've had all kinds of things coming out, but a lot of it has not been peer reviewed at this point. We do know how the virus enters cells. I talked about the spike protein, but it does use the human ACE2 receptor in the body. It fuses to that and enters the cell. So that spike protein hooking up there. And that's something that a lot of the targeting has been focused on. One of the cases we saw early on, we've seen this both in the 2003 outbreak and in the 2015 outbreak, is this concept of what we call super spreaders, that one patient can spread to multiple people. And what we know is that if you look at some of these past cases, we've seen the super spreader effect. Common infection, someone becomes infected and spreads that to a few other people. But in a super spreader status, they can spread to multiple people, and the reason is because they don't have symptoms and they're spreading it to multiple people and no one knows. We also early on had several outbreaks on cruise ships. As you know, these are confined spaces, and as we're seeing now with some of the naval ships and aircraft carriers, lots of cases and deaths on these cruise ships. And so we had early quarantining on these cases and shutting down of cruise travel. Also very early on, we had a lot of outbreaks, specifically in Seattle, Washington was the first one that we saw at Life Care, but we're continuing to see this even in Oklahoma and across the country in these nursing homes where some of the staff, are potentially becoming ill, coming in, and then those highly vulnerable people in the nursing homes are becoming infected, high mortalities in that population of patients. So one of the things is when you go back and you look in Washington State, this is from the Seattle flu study, an investigator there called Trevor Bedford. He has a pretty active tracking system, but he's been looking at all of the different strains that are coming out. And he looked primarily at what's coming into Washington. It was from Wuhan. Multiple mutations are occurring, but it's only a single introduction. As you can see here, this was from March 11th, but that single introduction has created the downstream effect. One of the concerns is always mutation. He has looked at this and he feels strongly that really there's a single strain. It does go through multiple mutations, but doesn't feel like the spike protein has changed. So therefore, that's the major mutation we'd be watching for. So that's the mutation that's concerning, is if the spike protein changes, then that would change the ball game, but right now that has not. How does it spread? It seems like every day we read case reports of some other way of spreading. But primarily it's still through respiratory droplets and other infectious secretions. We use the 6 feet. Some case reports have put it out, some studies have put it out to 13 feet, others to 27. There's some videos out there demonstrating spread across supermarkets. But right now 6 feet is the recommendation. As you know, here in Oklahoma, several people are wearing face masks as going to the stores. That was recommended by the White House Task Force. So the point of that is to try to limit that close contact and distance yourself. This is actually an article that was published and actually subsequently published in New England Journal of Medicine. But on top, it looks at the COVID-19. At the bottom, it looks at the original SARS strain that we saw in 2003. And it looks at how it does from a standpoint of, if it's an aerosol, if it's on copper, cardboard, steel, or plastic. You can see across here the time schedules. It does seem to last a little more on cardboard than the original strain, but the others all kind of match up very similarly across the board. Symptoms, again, 2 to 14 days after exposure, commonly we're going to see fever, breathing difficulties, cough, shortness of breath, some case reports of diarrhea or GI symptoms, nausea. In the severe cases, obviously pneumonia, respiratory distress. Treatment at this time, as you know, there's no vaccines. We do have some antivirals available that are being tested. Hydroxychloroquine is being used, and then just supportive therapy. This is just a comparison table. This was published by the Oklahoma State Department of Health, looking across the spectrum of COVID-19, the cold, flu, and then allergies. And so you can see the general symptoms. Of course, this is general. These are not always, but these are the common that we find. So who gets symptomatically infected? This is the China data. And when you look at this from an age standpoint, that red box that we're looking at, anywhere from 30 to 79, those are the highest risk across every aspect of China that we were looking at. When we look at the breakdown by sex and age, you can see it's pretty uniform. The cases break out pretty evenly, so that's interesting to look at. As you know, some of these case reports came out as it related to the multifocal infiltrates that these patients had. So these were published in the radiology press in January, and this was a very early tip-off to what we were seeing with this virus. So what are some of the risk factors? Elderly patients with underlying conditions, diabetes, cardiovascular disease, lung disease such as COPD and asthma, immunocompromised patients. Obviously, healthcare workers who are on the front lines taking care of these patients are at high risk. When we looked at data in China and then subsequently coming over to the US, the young patients don't seem to have the high mortalities, but certainly the elderly patients do. When you look at the case fatality rates in China, it's about 2.3%. Males had higher rates. Those with underlying health disease such as hypertension, diabetes, cardiovascular disease, chronic respiratory disease, or cancer had higher rates. They did not have any deaths in kids 0 to 9 years of age. And one of the questions about kids is, can they catch it? And of course they can catch SARS-CoV-2. They just aren't as likely to show symptoms. And this is kind of a scary fact that they found in China. These are people who did not have symptoms but were tested. They were contact-based. So a family member is diagnosed and they wanted to test the family. And what they found is that about 15% of these kids 0 to 9 years old tested positive, but they had absolutely no symptoms. And that is somewhat concerning because the kids could pass this along to the adults and grandparents and great-grandparents. So when we look at the R0 value, so this is the spread value, how easily this can go from one person to another. And remember, when that R0 gets below 1, that's our goal, is to get it down so it kind of dies out. But you can see in 1918, the Spanish flu was 1.8. The 1957 pandemic, which was in Asian, which is 1.65. 1968, which was Hong Kong, which is 1.8. H1N1 in 2009 was 1.46. Seasonal flu is about 1.28. And this is based on, and this is changing, but 2.79 is where COVID-19. So obviously it's spreading at a much higher rate than some of these others. Now, we have the benefit of these other ones. We have all the data. We don't have all the data yet on SARS-CoV-19. So that probably, hopefully, will come down. So what are some of the myths and realities? Get a lot of questions about this, but are hand dryers effective in killing the virus? No. That's why we recommend cleaning your hands frequently with an alcohol-based hand rub or soap and hot water. Can UV disinfectant lamp kill the virus? On patient skin, it should not be used to sterilize hands for obvious reasons. How effective are thermal scanners? Thermal scanners are only effective in detecting fever. They're not effective for viral detection. Can spraying alcohol or chlorine all over the body kill the virus? No, in fact, that can be more harmful to do. They're used and they're very useful for disinfecting surfaces. Is it safe to receive a letter or package from China? We do believe that it is safe. We don't believe that people are at risk of infection by getting a package from China. Can patients at home spread the virus? I put a question mark here. There was some thought early on that no, they couldn't, although we have seen some case reports in cats, not in dogs at this time. So we have to kind of put a question mark there at this time. Do vaccines against pneumonia protect against the novel virus? No, there's no vaccines at this time that would offer protection. Can regularly rinsing your nose with saline help prevent infection with the virus? The answer is no. Saline rinses aren't going to be effective at this time. Can gargling mouthwash or protect from infection from the virus? And the answer is no at this time as well. Can eating garlic help with preventing infection of the virus? The answer is no. We don't have any data. Sesame oil, does that work? Could we put that on areas to prevent it from entering? The answer is no at this time. We don't have good data on that. Does the new coronavirus affect older people or younger people also susceptible? We do believe that anyone can be infected at any age. Those with pre-existing medical conditions, asthma, diabetes, heart disease, pulmonary disease, cancer, immunocompromised states would be at higher risk. Are antibiotics effective in preventing and treating the virus? No, not at this time. There are some case reports of specific drugs being tested, but we have no good data at this time. Are there any specific medications to prevent or treat the virus? I would just say that some treatments are under investigation and will be tested through clinical trials. I just wanted to put this on here because there's been a lot of discussion about community spread, social distancing, incubation period, pandemic, epidemic. So I put some of these terms on here. I thought it was a good summary list just to think about as these terms are thrown around. On the treatment side, again, these are all off-label, but these are some of the agents that are being used. So remdesivir, this is an agent that's being used as positive in animal models and now is available to be used through compassionate care. Lopinavir, ritonavir, which is an HIV medication, a protease inhibitor, has been studied, and there's been some not positive data on that, not good outcomes. There's some other broad-spectrum antivirals being tested at this time. Chloroquine and hydroxychloroquine, hear a lot about that in the news. There's been some small studies, some small use of this, but again, not a well-randomized trial with placebo control. Targeted drug design is being studied, and monoclonal antibodies are being isolated and tested. This slide here, this is from a Seattle intensivist. This is a one-page sheet that he's been using to kind of, and he's been updating it very frequently, but it's basically an assessment sheet that he goes through as he works up patients and has some good data. I thought that would include that for completeness. On vaccines, I think one positive note is if you look at the history of some of these infections, it takes a long time to get vaccine developed into the first human injection. The coronavirus, really, we are on record pace to develop a vaccine for that. And I think so many companies are in the mix really trying to get after that. So really excited about the fact that we could have a vaccine. Again, it's a ways off, probably in the fall, if not further along than that. Vaccine development takes a long period of time. Just a brief summary. Remember, this was first reported in China in December 31st of 2019. It probably jumped the animal species and then went to humans. We got the gene sequence on January 10th from China, and that's when we were able to develop testing from there. And so we're really starting to, obviously testing was slow, but now it has ramped up dramatically. We don't have any groundbreaking discoveries to treat this at this time. So one of the ways to track this, and this is data from last night, this is the worldwide data. This is, the websites are on here, but this is how I kind of go about tracking. So this is the worldwide data. You can see across the level here the number of tests and cases and deaths. If you drill down, click on USA, you get all the state data. So again, it's a breakout. You can toggle and look at the day before, looks at new deaths. Very helpful data to look at. This is the Oklahoma data as of last night. This gives you a good idea of where we are to date. This is from the OSDH. It looks very similar to the Johns Hopkins map that you all see published online, but this is specific to Oklahoma. This is the Tulsa County website, which actually is updated every day as well. Again, it gives you a sense of the number of cases, the number of active cases, and the spread by gender. This is a very helpful map. This is out of University of Chicago, but actually allows you to look at hotspots around the country broken down either by county or by state. And if you go into this map and you select by variable, you can look at several different variables, including counts per 10,000, counts per bed, deaths. But it gives you a look down at the county level of hotspots around the country. This is an interesting map. This is a map that looks at social distancing around the country, and it gives grades per state on social distancing. I don't know that I like a lot of the data in here, but it's another map that's out there. But it helps track a lot of the social distancing. This is the IHME website that you hear a lot about, looking at projections. So this is fed in from real-time data and updated about every 48 hours. This is Oklahoma data. I'm looking at our peak at this point of April 30th. But this is a website out of Washington. This is the same data, but it's through a different website. And the nice thing about this model is it actually tracks the projections based on the model date. So, you know, when we started out on 325 in this model, our modeling was projecting us very high. Now we're out at 412 and it's got us very low. So this shows how real-time data can shift the model. And it's very helpful to look at from a time frame standpoint. I just wanted to give a brief update on the OSU COVID response. As you know, OSU is a land-grant university. In OSU Medicine, we focus on rural and underserved Oklahoma. This is OSU Medicine as a whole, looking at our education, residency programs, healthcare delivery, and research enterprise. So as you know, we've been really working hard to kind of support the state in this endeavor. Dr. Stroup is on the governor's COVID-19 Solutions Task Force. Our testing capacity in collaboration with the OSU School of Veterinary Medicine, Stillwater, knowledge sharing. We've been running echo sessions 3 times a week. Our primary care capacity with launching telemedicine, and then our treatment expertise locally in the state. So really, we've really focused on statewide testing, PPE procurement, provider readiness, surge planning, crisis care, focusing on standards documentation, expansion of healthcare. So really, we've really tried to push out front there to try to be ahead of this. This is our OSU Center for Health Sciences website, which has a coronavirus section. And then if you click on the guidelines over here, you'll come up with this medicine handbook, which is updated weekly, which goes through our care. Just from a COVID response standpoint, this was released by the governor last week. But as you know, the healthcare system in Oklahoma has surge plans. Once we expand over those surge plans, we'll hit the safety net, which is the COVID flex facilities, which OSU Medical Center is one of those. And then we will go to the non-COVID flex facilities at that point. Our hope, based on the model, is that we stay within the surge plan, but we have the flexibility to move out from that with appropriate planning. So really what we've been trying to do from the get-go is flatten the curve through prevention. Everybody keeping calm, washing your hands, staying home, social distancing, wearing face masks when appropriate, using telemedicine to contact your providers, and when you have symptoms, get tested. So those are our mitigation strategies. And with that, I will field any questions, although the data changes every day, so these slides may be outdated in a week. You never know. Thank you.